Internationally, he has been very famous and numerous international awards, including the World Glaucoma, ARVO, and AAO. So let me introduce Dr. Lian, please. Thank you.
Thank you for having me to talk about something that we did in Hong Kong, which I find it to be also relevant to share with you this afternoon. Hong Kong is a beautiful city, but it's also very crowded. We have a population of 7.5 million, but we have less than 400 ophthalmologists in Hong Kong. And over the past 12 months, we have over 150,000 of individuals requesting to see an eye doctor. So the healthcare system in Hong Kong is like when you are having an eye problem, you need to go through the GP to get a referral letter, and then you send your referral letter to the specialist outpatient clinic in ophthalmology. And this is the number, the volume that we received under the hospital authority, which is the government entity serving over 90% of the population in Hong Kong. So the workload is heavy, and this is not surprising. There are a lot of cases, half of those who are considered stable, they were given an appointment in a year, sometimes up to 2 years. So it's not acceptable. A lot of these referrals are written by general practitioner, physician, that they may not have even a visual acuity measurements recorded in the referral letter, making the triage extremely difficult, and we are missing a lot of time treatment window for patients with cataract AMD. So in this background, we were thinking 2-3 years ago whether we can actually scale up the way we diagnose eye disease in our community. We partnered with others. I'm a glaucoma specialist. I have a special interest in glaucoma, and that's why we're thinking, well, maybe we can provide an opportunity for our citizens in Hong Kong to have an eye screening using the latest ocular imaging technologies. We were more ambitious because we think it would be a good time not only to detect glaucoma, but also all major causes of vision impairments, including AMD, wet AMD, cataract. In Asia, so yes, Asia Pacific region, we see a lot of angle closure cases, and we would like to gather these cases, we would like to identify these cases early, because these conditions are treatable, and we can help lower the burden of vision impairment. And this is how we started the project 2 years ago with others. Now back then, the question we had was, what instruments shall we bring in to detect eye diseases? Now, OCT obviously is an important tool to identify macular pathologies, to detect glaucoma, but we also need fundus camera. We also need a fundus image to look at the optic disc morphology, to look at the presence of diabetic retinopathy. So we need fundus camera, we need OCT. We also need a tool that allows us to examine angle closure. Because this is, again, a prevalent condition, it is a blinding condition. So we thought carefully what instruments that we need to bring in. A lot of us here are using different types of OCT platforms. This is Spiralis, and we can image it. We can image the retinal nerve fiber layer, but the limitation here is the current platform, even the latest platform, we can only scan the nerve fiber layer in a circle. We can measure the rim, but a lot of time we can miss early cases. Like in this case, when we're able to look at the map, when we are able to look at the distribution of retinal nerve fiber layer, we can see an early retinal nerve fiber defects of the supratemporal cortex. Now I will show you later why I believe this is retinal nerve fiber defects. And in this series platform, not only we can look at retinal nerve fiber layer over the optic nerve head region, but we also can look at ganglion cell in the platform layer over the macula. We know we need a wider field, because wider field gives us a better capacity to identify early changes. Now in this case, when you look at the circumpapillary profile, 12 hours, 4 quadrant retinal nerve fiber thickness measurements, they are all normal. When you look at the map, you can see some hints. But only when you are able to see a wide field picture, you're able to connect everything together, and you're able to trace the retinal nerve fiber defects from the optic nerve head to the macula. The fact that you're able to see the pattern, which is a wedge-shaped pattern, over the thickness map and the deviation map gives you high confidence that there is something wrong in this eye. So we think back in the time, the Triton was the only instrument that can provide a fast, efficient, and wide field imaging of both the macula and the optic nerve head, and give us a wide field visualization of the retinal nerve fiber. That's why we selected the Triton. The speed, 100,000 A scans per second. The swept source, light source enable us to see deeper, not only important for glaucoma, but also for other macular and retinal pathology. Now, I think the beauty of the device is that we can image the wide field 12:9 scan in seconds, and this is how you see this live demonstration illustrates. You can see that at the very end, there is a flash which show up in this slide. What it meant here is it automatically also captured the fundus image of the optic disc, which is great because we can then have in one device serving two purposes. And we can have the optic disc morphology examined, we can examine the macula, and we can examine the retinal nerve fiber. So this is cool. The downside here is we also know the current paradigm of examining retinal nerve fiber is not sufficient. A lot of time we see these false positives, a lot of red flags of the map. It happens not only in the Triton device, it happens to any OCT devices. And that's why we developed a technology called retinal nerve fiber optical texture analysis, which enable us to see the individual axonal fiber bundles. We can see the papillomacular bundles, we can see the temporal raphe, we can see the superior arcuate, inferior arcuate, and less often, this is the structure that is so difficult to visualize, is the radial nasal bundle. Now, with the technology Roger, which is a software, which is an algorithm allowing us to process OCT data from any OCT platform to let us visualize the anatomy and pathology. That's why we also included rotor in our community setting, because not only we are now able to measure the thickness, but we're able to tease out the trajectories and to diagnose glaucoma and other optic neuropathies in high sensitivity and specificity. This is a slide I just showed earlier, and I know this is retinal nerve fiber defects because you can see how rotor enables the visualization of the nerve fiber defects much better than the conventional tool. Now, I said the Triton device provides the capability to image the fundus, but oftentimes we find it just the quality not good enough. The recommended pupil size is 3.3 millimeter, and this is when you see a problem where we don't have enough light illuminating the retina. And that's why for that project with APACRS, we also brought in the fundus camera, because we really need good high quality photograph to examine the disc. We don't want to dilate the pupil because we don't want to do mass examination. And small pupil are common, especially over 50 years of age. And that's why we brought in AIDEN, which is a very good device to examine the fundus. We also know gonioscopy is difficult to perform. It's almost impossible to ask an optometrist or technician to look at. The angles using gonioscopy is not reproducible. Sometimes the same grading, but you can have very different anatomy. One is angle closure, one is near angle. That's why we also brought in the CASIA2, which is an anterior seminal CT. So with 3 instruments set up at 3 and 4 different sites in Hong Kong. And this is just a capture of what we did in the community clinic. You can see all these instruments over there. Hong Kong is a small place and we are very limited in space, and that's why everything crammed together. And so we received very good response. We also measure the visual acuity, we measure the IOP. We set up 4 sites, and over the past 2 years, we examined over 5,000 individuals. We provided free exam, and they all had OCT fundus camera, and anterior segmental OCT examination. Now, the findings of the studies are very interesting. We found almost 7% of our population in Hong Kong over 50 years of age had glaucoma. By the way, this is a population-based study. We randomly identified, randomly selected individual Hong Kong residents over 50 years of age to participate in the program. So this is a population-based prevalence estimates. And a lot of them actually also have retinal nerve fiber defects, but without vision loss. Remember what I mentioned earlier, that we also examined the optic disc carefully. And we define glaucoma by having both retinal nerve fiber defects on rotor, as well as corresponding loss of the new retinal rim evidence in the optic disc photograph. Over 70% of our population, they were not aware of the disease when they were diagnosed with glaucoma. I don't have time to share with you the findings of other studies of other diseases. We also detected macular diseases, we also detected angle closure. But just to showcase how we can use advanced ocular imaging devices together with AI and other tools to make diagnosis early. And in this case with CNI, it looks like there is an inferior vision loss. It looks like a glaucoma, but in this case, we don't see any retinal nerve fiber damage. So we have AI to show us a probability that telling us this is not glaucoma. So even though at this community centers, at the time of examination, we may not have ophthalmologists on site, but with optometrists, with a technician, they can tell with high confidence whether this eye is abnormal or not. Now, in this case, the rim looks intact, the capture-to-disc ratio is normal, yet in this eye, we see a clear retinal nerve fiber defects. Now, this case, we don't call it glaucoma, we call it a retinal nerve fiber defects of unknown origin. A lot of times, we see these cases are associated with diabetic patients, associated with hypertension, associated with patients with systemic vascular diseases. Now, we need the 3 instruments to detect different type of eye diseases. Now, the recent introduction of the Triton2 perhaps can change the picture to a certain degree. As I said, Hong Kong is a small space, and we need really compact and high-performing instruments to identify disease early. And I would like to show this is perhaps an important development which allow us to look at the fundus in good clarity, OCT, A in wide field, rotor, as well as anterior segmental OCT. Some of these features are new. And one thing that I really enjoy using the Triton2 is the new fundus camera, which is a slit scanning photography system. The slit scanning is a cool technology because it is based on slit illumination, and through the slit illumination, what we can achieve is that we can image pupil undilated, even to a pupil size of 2 millimeters. And this is how we scan the eye using the slit scanning technology, and with that, we would be able to get good illumination, reduce scattering, and high quality photograph. And this is what we see, the differences in the specification. We can see a larger field can be captured and a smaller pupil achieving high quality images. This is the same eye imaged by both the older system and the new system. And you can see the illumination is better and the details are richer, and especially over the peripheral side, the illumination is not good enough, and you can see the blood vessel trajectories can be vividly visualized even over the side of the retina. Some pathologies, some features, the size have peripheral drusen, which actually are not quite well seen with the old system, but with the new system, we're able to pinpoint, we're able to count individual blots of blood on drusen. Here is, and now you can see it's almost impossible to get a good quality fundus image without dilation. In this case, we were able to get good examination of the optic disc and the macula. For pupil, we put 2.6 millimeter, which is small, and in a lot of cases, we see very dim peripheral retina, but with the Triton2, we can see pretty clear illumination, both at the center and at the peripheral. Some cases, obviously, actually is quite common, as I said. If we're not dilating the pupil, very often we ended up with this, and cataract obviously could be an issue. But with Triton2, even from the same eye, we get a very different visualization. It's automatic montage is also available. We can get a wide field examination. We can look further away. I like ADEN because it gives us wider field of view, even compared with Triton2 camera. But one thing that I don't really like about ADEN is the fact that oftentimes it's over-illuminated, particularly over the optic disc region. I've talked to the company and I hope they are improving the technology, but Triton2 give you a more kind of original color and you can get the better understanding, especially over the deep optic nerve head structure. The new feature of the Triton2 also included the wide field scan, 21 by 21 millimeter OCTA, and with denoising, we are able to get this kind of a technology allowing us to see a clearer, crispier, higher signal to noise ratio representation. OCTA is good in the sense that for a lot of diabetic eyes, we would like to check whether there is ischemia. Now, anterior segment OCT is something not new. It's available in the Triton1, but it's also available in the Triton2, which is, I believe, is a good tool for screening, for detecting angle closure, even though it's not as comprehensive in a way as the CASIA 2 or instruments that are specifically designed for anterior segment imaging. We're able to get a good understanding of whether an eye has angle closure. So we can image the posterior segment and anterior segment OCTA in one single instrument, which I find it to be perhaps quite cost effective, especially if you are deploying the instrument in busy clinic and also in our project where we screen lots of patients in the primary care setting. So last year we were awarded $5 million for the government to promote the use of AI and the advanced ocular imaging instruments to identify eye diseases early so that we can treat early to alleviate the long wait time, to alleviate the heavy patient load we see in Hong Kong. So the scheme that we put forward here is like we would like the patient and refer patients who are considered to be relatively stable, they will be first to be examined in family medicine clinic or community clinics. They will have their eyes imaged by OCT, anterior segment, posterior segment, rotor, and for those with identified eye diseases, they will then be triaged to see an eye doctor in a specialist outpatient clinic. For those with dry eyes or refractive areas, they can be managed at the community center or family medicine clinic. So just to recap, I think these are very good features, and if you would like to think about whether we can have a all-in-one multimodal platform to perform cost-effective examination of eye diseases, detecting eye diseases early, I think Triton2 could be a consideration. The fundus camera, I think, is very good right now. I think it's a much better version compared with the previous one. And the wide field OCTA up to 21 millimeter could be very useful, especially if you're looking into diabetic retinopathy, checking whether ischemia happening most often actually not over the center, not over the macula, but over the peripheral retina. And then the AI-driven technology allowing us to denoise, to segment, and I think I'm so excited that rotor will be available in the new glaucoma dashboard in the Triton2 device. I think these are all very, very exciting developments that we look forward to see. Thank you very much.